Good evening, and thank you for joining this evening's telephone town hall meeting with Congressman Andy Barr. Congressman Barr will be joined by Dr. Charles Kennedy, who has served as the hospital epidemiologist at St. Joseph's Hospital since 2001 and is an infectious disease specialist, to give you an update on the coronavirus pandemic and answer any questions you all may have. In a moment, Congressman Barr and Dr. Kennedy will begin with a few remarks to give everyone time to join the call. This technology allows people from around the 6th District to join us live to ask questions from your congressman. If you have a question for Congressman Barr or Dr. Kennedy, please press star and then 3 on your phone. Again, that is star and then 3 to join the queue to ask a question. With that, I'll turn it over to Congressman Barr first to update us on the federal response to coronavirus, and then to Dr. Kennedy to provide his medical expertise on the coronavirus.
Good evening, everyone, and thank you for joining us tonight for this important update. Today, obviously, as many of you have heard, the World Health Organization declared a global pandemic and said it is deeply concerned by the spread and severity of the COVID-19 virus. The first report to the World Health Organization of what is now called SARS-CoV-2, a novel strain of coronavirus, was made by China on December 31st, 2019. This is a new viral variant that causes the current coronavirus disease, COVID-19, and is in the same family of viruses that cause the common cold, the 2003 SARS outbreak in China, and the ongoing MERS outbreak in Saudi Arabia. Coronaviruses are not new or mysterious viruses as sometimes described in the media. Nevertheless, the numbers are worth noting. We have over 80,000 confirmed cases in China and more than 37,000 cases in more than 100 countries and territories outside of China. In Kentucky, we are monitoring coronavirus confirmed cases. We have 8 positives as of 5:05 p.m. Eastern Time in Kentucky. 64 individuals have been tested in Kentucky, 56 negative. So that's where we stand in Kentucky with this. While we are certainly taking the threat of the coronavirus seriously, as the situation could change very, very rapidly, currently, it's important to emphasize, currently, the threat to the average American today remains low. As I said before, in the Commonwealth, we are currently monitoring 8 confirmed cases. Rest assured, the most recent Global Health Security Index rated the United States as the
number one.
Hi, this is Dan with
Congressman Barr's office. Hi, this is Dan with Congressman Barr's office.
The Global Health Security Index rated the United States as the number 1 overall most prepared country in the world for an infectious disease outbreak. That is in part due to some major increases in preparedness funding over the last several years. Since fiscal year 2015, the National Institutes of Health has seen an increase in its budget by 39%. The CDC has seen an increase by its funding by 24%. Advanced biomedical research, we've seen funding increase 35%. The National Stockpile increased 32%. And infectious disease response funding has been increased by 70%. In addition, we also would point out that the resources and the capabilities and expertise of the United States are really the envy of the world, and we're also blessed with a robust response from the private sector, and I'll detail that in a minute. Congress and the executive branch are taking a whole-of-government approach to combating this epidemic, and the federal government is deploying its extensive national resources in response. The CDC and the NIH, Department of Health and Human Services, and CMS, all of these healthcare agencies are on top of things, and they're keeping Congress apprised. We're getting routine and daily briefings from top officials in charge of the federal response, including both the Vice President, who's leading the task force in response to the virus, as well as Dr. Fauci, who is the lead on infectious diseases at the National Institutes of Health. Last week, Congress passed, with my support, and the President signed into law, a bipartisan emergency funding bill to empower our federal agencies, state governments, and communities nationwide to combat the COVID-19 virus. This was an $8.3 billion package. It includes over $4 billion to expand diagnostic tests, treatments for those affected in vaccine development. In addition, over $2 billion will be allocated to the Centers for Disease Control and Prevention, the CDC, to bolster their efforts to lead our nation's response to the virus. And lastly, over $1 billion in funding will go to the U.S. State Department and the U.S. Agency for International Development, USAID, to support their efforts to protect the nearly 9 million Americans who live abroad in diplomatic, humanitarian, and other capacities. Kentucky specifically will receive over $7 million immediately, and we will certainly be monitoring additional funding to the Commonwealth. My staff has been in contact with the Department of Health and Human Services to ensure that these funds are delivered to the Commonwealth as soon as possible.
As a reminder, and for anyone new joining the call, if you have a question for Congressman Barr, please press star and then 3 on your phone. Again, that is star and then 3 to join the queue and ask a question.
So in summary, COVID-19 does, in fact, present a threat to public health and the American economy. I know many of you have been following the repercussions in the stock market, but I do want to emphasize as a major caveat that the data thus far does not support that this is a more significant of an event than the 2009 H1N1 influenza pandemic. And I will invite Dr. Kennedy in a moment to discuss his views on this, but at this point in time, during the 2009 H1N1 influenza pandemic, the number of deaths in the United States was 14 times higher than from COVID-19. What we are being told by many of the experts and the epidemiologists in the country and at the National Institutes of Health is that over 80% of those who contract the virus have more mild symptoms, but this is a very serious pathogen for those over the age of 60 and those with compromised immune systems. As I mentioned, we're taking a whole-of-government approach in our response to this epidemic. This is allowing us to engage public health officials, the private sector, academia, nonprofits, all together to solve the challenge in front of us. What we really need right now and what we're working on are therapies and a vaccine. It's a real credit to both the government's response and the private sector that the pharmaceutical companies are already working on clinical trials with antivirals and other therapies. The swiftness, the speed, the agility of the scientists, innovators, and investigators at these pharmaceutical companies is really unprecedented. We received a briefing from the chief medical officers of all of the top pharma companies in the world, and they're already, thanks to expedited procedures at the FDA, they're in clinical trials in China and in the United States, and we're being told that the first vaccine could be an experimental clinical trial as soon as 4 to 6 weeks from now. That doesn't mean we're going to see a vaccine this year. It could be 18 to 24 months before we have a vaccine, but the antiviral therapies may be available to us sooner rather than later. So they are really moving with quite a bit of speed, and that's a good thing. Part of the supplemental appropriations that we provided for last week that will be going towards expediting the development of these antiviral therapies. Also, some of the money is going to more testing kits. The commercial labs are coming on board now and aiding in the expediting of the capacity of the test development and dispersion. That is the concern of our local doctors in Lexington, is the availability of the tests. We cannot stop the spread of this if we don't have more access to tests, and we're working on that. As of last week, more than 1 million tests have been shipped out to the states, and 4 million more will be distributed this week. These are encouraging developments. I would like to end on an optimistic note. What is encouraging through the whole-of-government approach, the administration has lifted some of the bureaucratic red tape impediments to the development of some of these therapies and vaccines. The FDA is doing all the right things in my opinion, in terms of allowing more laboratories to come online and facilitate more tests. Congress took responsible action in a bipartisan way, a very bold and aggressive emergency spending package that will help our state and local public health authorities deal with the issue. And I have spoken personally with Commissioner Steve Stack at the state level as these resources are being transmitted to the Commonwealth. Finally, and I'm sure Dr. Kennedy can address this further, medical experts tell us that as temperatures rise in the summertime, that will naturally beat down this virus and the spread of the virus. Right now we are seeing an acceleration of person-to-person transmission, but as the temperatures rise, we could see a diminution of the spread of the virus heading into the summer season. So as a reminder, just in conclusion with my opening remarks, if you have a question for me or Dr. Kennedy, please press star and then 3 on your phone. Again, that is star and then 3 to join the queue and ask a question. And I will now turn it over to Dr. Charles Kennedy to give some brief remarks. And I just want, by way of introduction, I wanted to thank Dr. Kennedy, who is a very well-respected epidemiologist, infectious disease a practitioner in our community. And I know he's very busy at this time, so I'm particularly grateful for his time to help inform the public here. So I'll turn it over now to Dr. Kennedy with my gratitude.
Congressman Barr, I appreciate the kind introduction, basically, and I think that was a very comprehensive review of the state of the COVID-19 pandemic. Many people listening this afternoon basically have probably already been privy to the governor's press conference, and he described today as, quote, a good day in the life of the Commonwealth. 11 patients which were felt to be high risk on the basis of exposure and CDC-defined risk factors were tested in the preceding 24 hours. 10 of them were definitively negative, and 1 of them tested in an inconclusive or equivocal fashion. So the fact that we're not having a logarithmic expansion of cases from day to day throughout the Commonwealth, I think is profoundly encouraging. With that said, given the incubation period of the virus between 2 and 14 days, you're always essentially going to be 2 weeks out from your last documented case. So I think vigilance basically is incredibly important, and you see that with current recommendations coming down with regards to visitation in nursing homes and extended care facilities, state and federal prisons, some college closures, and other campuses converting largely to an online curriculum for the remainder of the academic year. So once again, simply to emphasize basically is that there has not been a significant uptick in the number of documented cases over the last 24 hours. And again, on the basis of the governor's press conference, it appears that one of the patients who was hospitalized in Louisville has actually been discharged home.
Very good. Thank you, Dr. Kennedy, and I'll turn it back over to Claire.
Thank you both for your updates. And as a reminder, if you do have a question, you want to press star 3 on your phone to get that question in the queue. So we'll turn it over and take our first question now from Edward from Lexington. Edward, you are live now.
Edward, go ahead with your question.
Okay, I thought the person I spoke with earlier was going to ask it. What impact is the pandemic in China and also worldwide having on the supply chain for pharmaceuticals in this country? As I understand, there's very few places in the world where a lot of the chemicals used in the manufacture of pharmaceuticals is limited to China and India. And what does the U.S. government plan on doing about that in the future?
Well, let me just say, when we were in the meeting with the chief medical officers of the pharmaceutical companies themselves, they did not raise that as a concern. But I would also invite Dr. Kennedy any perspective that he might have on that.
I think it's accurate to say that a fair amount of pharmaceutical manufacturing that's actually utilized in this country does have either complete production in China or partial component production in China, which is necessary to complete the chemical composition of the drug. And so at the present time, while that's a theoretical concern, my sense is, as a practicing clinician, basically, that there has been no reduction in supply chain to commonly used pharmaceuticals in which they are in toto produced in China or in part produced there.
Thank you.
Okay, and I have another question. The president has proposed.
Thank you, Edward. And now we are going to take a question from Rebecca in Lexington.
Rebecca in Lexington.
Yes, my question concerns households that have a mix of vulnerable individuals with younger adults that go out into the community and school. Are there any plans or any measures that are going to be taken to help people to separate those populations? Like, for instance, my parents are both nearly 90 years old, and my brother lives with them, and he goes out and works. Suppose he developed this infection. Is there any place or any facility that he can go to be segregated from them so that they don't contract it too?
That's a good question, Rebecca. What we are being told at a congressional level is that a situation like that, social isolation, self-isolation, would be prudent for those individuals. Let me invite Dr. Kennedy to offer his medical opinion on that.
Okay, thank you.
No, I think that's accurate, basically, and the nomenclature that's kind of being parlayed about is this concept of social distancing. And what we do know from clinical experience, basically, that individuals at highest risk of acquiring the infection usually require relatively close contact with an infected individual. And that's been essentially defined as a 6 foot or less distance for a period of time in excess of 5 minutes from a patient who is actively coughing and actually aerosolizing virus. So it's one of those situations, I think, where if you have elderly, vulnerable parents with medical comorbidities, and you have a younger individual in the household who develops fever in excess of 100.4 degrees in association with cough or shortness of breath, that just the common sense educational dogma suggests that distancing yourself from relatives at risk would be prudent.
Thank you.
Thank you.
Thank you, Rebecca. And now, just as one more reminder, if you are new to the call, to press *3 on your phone if you have a question. Now we will take a question from Nicholas in Lexington.
Nicholas, go ahead.
My question is, over the last few years, I think with the federal budget, there's been a reduction in funding to the CDC, and I was just wondering if there's been discussion now with this COVID virus going around that if they're planning on increasing the funding back to the CDC.
Yeah, so the funding actually to the Centers for Disease Control has since 2015 has increased overall by 24%. So there's been a significant increase in funding. In addition, I'll point out, in addition to that, last summer, the President signed into law the Pandemic and All Hazards Preparedness and Advancing Innovation Act, which reauthorized our nation's public health preparedness and response programs to give federal, state, and local officials the tools they need to quickly and effectively respond to ongoing threats. So there has been some anticipatory action here, but obviously, in light of this, we're going to monitor it. We're in the appropriations season. We will take very seriously, Congress will take very seriously any requests from the CDC if they report to us that they need more resources.
Okay, thank you.
Thank you. And now we will take a question from Mary in Lexington.
Mary, go ahead. Mary, are you on the line? Mary
Yes.
from Lexington.
Yes. Hello.
Yes, go ahead.
Yes, I would like to know, even if you don't have symptoms, do you need to be tested? Does everyone need to be tested? And where can we get tested?
We are told that is not necessary. The testing, in fact, what the emergency room physicians and the epidemiologists, they're a little concerned that if people who are not sick, who do not present symptoms, are seeking medical treatment or seeking tests, that would exhaust the the limited supply of tests. If there is any problem in the response right now, it's that there is an insufficiency of tests, and we're working on that, bringing the commercial labs on board and deploying the federal resources from the emergency supplemental to procure additional tests and personal protective equipment, ventilators, and other things in preparation for a spike in the contagion. But let me also defer to Dr. Kennedy and get his professional opinion on that.
I think that's accurate, Congressman Barr. Our major limitation right now basically is driven really by a lack of what I would call point of contact testing. And at the present time, basically, when a patient presents with concerns about COVID-19, the risk assessment that comes down from the CDC involves originally travel to China, followed by a variety of other countries in Southeast Asia, and then most recently with a dramatic spike in activity in both Iran and northern Italy, or exposure to an individual who had traveled to one of those areas in combination with clinical symptoms of fever of 100.4 or greater, in combination with cough and shortness of breath. So in the absence, basically, of those CDC-defined risk factors, it's unlikely that an individual would have disease. And so right now, the testing really is approved by either the Fayette County Public Health Department, basically, or by the State Health Department in Frankfurt. In other words, there has to be physician-to-physician communication and a variety of criteria that I just alluded to in order to warrant testing. Otherwise, the yield of the testing, if we performed it on everybody who did not fit that criteria, but were simply amongst the worried well, would rapidly overwhelm our capacity to test. And in addition, it would put such testing pressure basically on the local emergency departments that it would quite literally be an overwhelming phenomenon. So if you're clinically well and you don't meet those CDC-defined risks that I just alluded to, there is no clinical indication for testing.
So what I would add, obviously, is that just continue. If you're well and you don't have any of the symptoms, then no need to go get a test, but continue to be vigilant in terms of your hand washing and your social distancing and all the other things that would be prudent to prevent contracting a cold or the flu or this particular virus.
Thank you.
Thank you. And now we have a question from John.
Hello, John. How are you?
I'm pretty good. It seems to me that there's a lot of concern about this that far exceeds what seems to be the percentages. While this is a coronavirus that, as I understand it, you don't understand it and do not have a vaccine, and that puts everybody at risk, the bigger concern, I would think, is when you look at a parallel condition, the flu, that is devastating some populations. The same populations that are at risk with this coronavirus are at risk with the flu, and the flu has a far greater death rate at this point as far as sheer numbers. So it seems to me that our concern is placed well, but the excitement and the hysteria is not well placed, not well controlled, and that we are overreacting from the population, that the attention from the epidemiologist could be focused on this without having stirred the public imagination. I feel that from everything that has been indicated, and unfortunately we get a lot of mixed messages, especially with this administration, that we're overreacting.
Well, I appreciate your comments. I'll let Dr. Kennedy respond as well. It is accurate to say that there is no currently FDA-approved treatment for any coronavirus, including COVID-19. The caveat, of course, as I said earlier, is that we We currently have some antivirals and some therapies that are in active clinical trials, and then we are being told by the pharmaceutical companies that they anticipate vaccines being ready to be tested in trials within 4 to 6 weeks. What I will say is that the data does not support that this is more, at least now, does not support that this is more significant of an event than the 2009 H1N1 influenza pandemic. The current case fatality report for COVID-19 is likely incorrect due to lack of widely available diagnostic testing. And so once the diagnostics are more available, once there's more testing, it's likely that the number of reported cases will go down, will go significantly higher. So you'll have more reported cases, but the fatality rate will go down because again, 80%. They're telling us that over 80% of the people who contract the virus have mild symptoms. So in any event, at least at this point in time, during the 2009 H1N1 pandemic, the number of deaths in the United States was 14 times higher than from COVID-19. So I think...
Yeah, but what kind of sheer numbers are you talking about? 14 times 1 is 14. 14 times 7,000 is quite a bit more. So, what kind of sheer real numbers are we talking?
Well, let me invite Dr. Kennedy to chime in on that.
I think if you look at the most recent data on the Johns Hopkins website, basically the current estimate of documented worldwide infections due to COVID-19 is about at 120,000 cases. As of yesterday evening, there were 4,200 reported deaths. So what has been widely cited in the literature basically is the current understanding of COVID mortality is somewhere between 3.5% and 4%. As Congressman Barr alluded to, though, this is probably artifactually elevated in terms of the overall mortality rate. And while I have no crystal ball and have no ability to project basically the future, what I would guess after having done this over the last 3.5 decades is that what you will see in the next year is that Chinese epidemiologists and investigators from the WHO will go into the Hubei province, basically, in which Wuhan, the epicenter of the epidemic, was located. And there are 11 million people that live in that Chinese province. And I think you'll see that what the Chinese will do is they will end up testing the blood on 1 million or 2 million Chinese citizens. And what you will find is that there was not 100,000 cases of COVID-19 in China, but in fact there was 1 million individuals that they've tested that have detectable antibody in their blood, indicating that they had been infected and either did not develop symptoms or did not develop symptoms that were significant enough to warrant medical attention. So as the denominator basically rises, the mortality rate by percentage will fall. And you're correct in some respects, basically, because seasonal influenza kills about 32,000 people every year in the United States. The issue with seasonal influenza is that we have a vaccine that's about 60% effective in blocking primary influenza infection. But the major benefit of the influenza vaccine is that it attenuates the severity of disease even amongst those individuals who develop wild-type infection. So in summary, basically, seasonal influenza solely on the basis of numbers is a larger public health problem in this country. The problem is really the virulent nature, basically, and the rapid spread of COVID-19, and the fact that we do not have established medical therapeutics and do not have a commercially available vaccine.
Thank you for your question.
Thank you. And as a reminder, if you have a question, please press star and then 3 on your phone. And now we have a question from Deborah.
Hello, Deborah.
Hello?
Yes, you're on the line.
Okay. Listen, how much is this going to cost the taxpayers to do all of this testing and stuff like this? Because if it goes into the taxpayers' money, is that also going to affect like senior citizens, Social Security, and all that for medical?
No, it will not. The appropriations from Congress last week is an emergency supplemental. It's not taken from the existing budget, or it does not impact those programs at all. And there are some of my colleagues who are calling for additional congressional intervention. I do not anticipate that happening this week, and I do not anticipate it happening next week. There could be, depending on how the economy performs during this pandemic. We will see whether or not there will be proposals to provide some additional fiscal stimulus in a couple of weeks, again, depending on how the economy performs. One thing I would note is that obviously, if to the extent we have social isolation, you may have heard about the NCAA announcement of canceling attendance from the public at some of these basketball games. I mean, obviously, this will have an impact. We did have a manufacturer in our community, in our congressional district, that let us know that 50 of their employees did not show up for work because of fear related to this virus. And so there is evidence that there is some interruption. Obviously, the stock market is taking a significant hit. But I think this is overall temporary, and Congress will kind of take a look at where we are in a couple of weeks and consider potentially some stimulative actions further. But it will not impact Social Security or Medicare.
Thank you, Deborah, for your question. And now we have a question from Dr. Loeffler.
Yes, Dr. Loeffler.
Yes, sir, gentlemen. Thanks for calling me. This is very timely. I appreciate it, Congressman Barr and Dr. Kennedy. So I am a hospitalist and critical care doctor here in the community. I work at a community hospital. I mean, I've got a lot of questions, but the most pressing one is one that I see as, the one that I think I can speak for my colleagues as well, both here and I've spoken with some of my colleagues at the University of Kentucky. Kentucky has an unhealthy population that we all know. They have many of the risk factors that place them at risk for the respiratory symptoms, respiratory failure. And I'm going to drop into medical speak a little bit, but pneumonitis, ARDS, adult respiratory distress, the non-cardiogenic pulmonary edema, things that put them on a ventilator. And if Italy is any indication, and I've been following this, I'm sure like any good doc, we've all been following it and getting ready. They've run out of ventilators. They've run out of critical care space. They are having to make terrible decisions about who gets a ventilator, and this is going on in Italy. Their healthcare system probably is, I think it's safe to say, on par with ours. And I understand that FEMA has extra ventilators, and what's the planning that's going on to get ready for this breaking wave of older at-risk COPD patients with heart disease, lung disease, hypertension, diabetes, obesity that we have here in the state, because we've got a lot of them in the state. And they are, like I said, that's the demographic for this COVID-19. That's my question.
Yeah, Doctor, good questions. You're not alone. We've heard from many other physicians in the hospitals who are asking similar good questions about that, and no doubt about it, we want the federal money that's coming to the Commonwealth to be used to help in the procurement of additional ventilators, if necessary, personal protective equipment, and then the testing, I think, is part of this, because we need to complete the standing up of the commercial labs. The FDA has cleared the way for that. But we do need to allow for quicker testing so that we can rule out patients that may be testing negative, so that we can prioritize the triage. And I think the efforts on the public health side and preventing the spread of this is designed so that we do not overwhelm the public health system. We've seen that situation in some of these other countries. The public health component in preventing the spread is important, so that the health system itself is not overwhelmed, and that there isn't that problem. But some of those details about how patients will be moved around, if necessary, that ultimately is going to be a state decision, but it is the federal role to provide the resources, and that and we stand ready to make sure we get our share of the federal funds that were appropriated last week to facilitate all of that. Dr. Kennedy, do you want to speak to that?
I think within the St. Joseph's Catholic Health Initiative system, in which I do the majority of my work, we've exerted really an extraordinary amount of time and effort, basically, in trying to define what our surge capacity would actually be. And at the present time, basically, within our system, there are an additional 40 ventilators, basically, that are in inventory to try and deal with surge capacity. For patients who have less severe hypoxemia and don't require positive pressure ventilation, there are an additional 30 CPAP machines that are available. We, through an emergency capital distribution yesterday, obtained, or in the process of obtaining, basically an additional 16 HEPA filter units in order to be able to convert intensive care unit rooms basically into a negative pressure isolation air delivery system. So as much as I can reassure the other physician, everything's being done at a local level to try and identify pre-existing negative pressure rooms to ensure that there's an adequate amount of ventilators and CPAP machines, even to the point of altering hospital HVAC and air delivery systems so that those can be vented to the outside, so that there's no commingling, basically, of the air supply to potentially vulnerable patients.
And Dr. Loeffler, I'll finally just take your concern and your question to the CDC tomorrow. I will be meeting with the CDC and the NIH tomorrow, and I will raise that question with them to make sure that the efforts to procure additional equipment is kind of put at the top of the priority list. Thanks for calling in, Doctor.
Thank you, Doctor. And now we have a call from Sarah in Lexington.
Hi. I was wondering what is going to be done for workers who will be putting themselves in a situation where they will be unable to pay their bills if they self-quarantine.
Well, good question. I mean, different employers are at this point in time implementing different policies for their employees. As we were discussing earlier with another caller, if you are not presenting with symptoms, not everybody necessarily needs to get tested or self-quarantine. There needs to be some common sense in terms of hand washing, and obviously if you have a coworker who is sick, you need to stay away from that individual. Congress may very well be considering, if this gets to that point where there are large numbers of employees who have to stay away from work, Congress may be considering some temporary relief for those individuals. There was some funding in the recent supplemental appropriations bill for some assistance for some businesses that have to have an interruption. But we're not going to take that up until we find out really whether or not there is going to be that disruption. If there is, obviously, if you are sick or if you have coworkers who are presenting with illness, they need to stay home. They don't need to be going to work, and that's the recommendations from the CDC and the experts.
Well, that's just it. People typically don't start showing symptoms for about 2 weeks. Also, there is no relief currently, so people who have been around those who are sick can't really stay home without foregoing pay, which is, how are they going to pay the rent? How are they going to support their families?
Well, right. Obviously, if you're not presenting with illnesses, nobody is recommending that you stay home from work. It's only if you are presenting with an illness, and I know the concern is that it's asymptomatic. I mean, it's you're just the advice from the government at this point in time is if you're not ill, you don't need to stay home from work. But 6 feet distance from others is a suggestion. And so if you're at a workplace where you don't have to be in the proximity of another person of 6 feet, and nobody else is presenting with any illnesses, there's really no recommendation to stay home. Thank you for the question, and next caller.
Thank you. And as a reminder, once again, if you have a question, please press *3 on your phone. Now we have a question from Ken in Lexington.
Hi, thank you for taking my call. Basically, I was just curious as to what type of treatment the COVID-19 patients are receiving who are quarantined at home versus a hospital, and about how long would you expect they might be in quarantine before they are released, as the patient in Louisville was today?
Dr. Kennedy, I'll let you take that one.
If you had a significant risk exposure, basically, and tested positive for COVID-19 by DNA technology, but were not in septic shock and did not have respiratory failure, you're essentially released to being being self-quarantined at home for a period of 14 days. I can only speak to the 2 patients in Fayette County with which my consulting infectious disease group is currently involved. In terms of therapeutics, basically, there have been a number of agents that have been looked at, largely in China, currently in Iran and northern Italy as well. And of some interest, basically, are older historical drugs that we used for malarial prophylaxis, particularly a drug called chloroquine, which seems to have antiviral activity, even though it was never used in the context of treating viral infections. There's an additional form of chloroquine that we call hydroxychloroquine, which is marketed under the trade name of Plaquenil, which is used as an immunosuppressive drug in a variety of rheumatologic conditions. There's also some data from China that the combination of Tamiflu, which we use frequently in this country to treat acute influenza A or B, has activity, particularly when it's combined with 2 HIV-related antiviral drugs called ritonavir and Kaletra. And there was some emerging data today that nobody expected, that a class of antihypertensive drugs, which are widely used in this country, called angiotensin receptor blockers, may also have in vitro activity in terms of killing the virus. So the patients that are currently being treated in the private sector in Lexington are receiving a combination of those drugs that I just alluded to. With regards to hospital discharge with documented disease, the current recommendation from the CDC is that individuals have consecutive PCR, meaning DNA testing, done on 2 consecutive days on either oropharyngeal or nasopharyngeal swabs. And when 2 consecutive daily tests are negative for viral DNA, they can then be discharged home.
Okay, we'll move to the next question.
Thank you. And now we have Creesa from Lexington.
Hello.
Hi, Creesa. How are you?
I'm well, thank you. Thank you for doing this conference. I appreciate it.
Yes, ma'am.
My question is, I read in Politico today that the CDC was lacking in tools and materials to rapidly develop a vaccine. And my question is, if we have to wait a year or a year and a half this turns out to be seasonal and it does let up in the summer, but it comes back in the fall, will we be ready next time?
Well, absolutely. That's a great question. And the supplemental appropriations bill contained $2.2 billion for the CDC. That included nearly $1 billion exclusively for the state and local response efforts. $300 million of that is for the CDC's Infectious Diseases Rapid Response Reserve Fund, which is a fund that prevents and prepares for and responds to diseases. That money for the CDC is that part of the money is not for the development of the vaccines and the therapies. That is from the $4 billion, which is a separate pot of money from the money that goes to the CDC, and in the $4 billion, there are that's for more diagnostic tests, and it's funding to support treatments and to invest in vaccine development. But what you should know is that that's not the only investment that's happening. There's a significant private investment that is ongoing, and while we do not anticipate a final approved vaccine for maybe a year or two, we do believe, and we're being told by both the government and the pharmaceutical industry, that the therapies and the antivirals that are being tested right now in the United States and elsewhere, there will be approved therapies that will be available before the next cold season next year.
Thank you very much, Congressman. That's very reassuring.
Thank you. And we'll move to the next question.
Thank you. And now we'll move to Winona from Lexington.
Hey, everybody.
Yes, hello, Winona.
Thank you all so much for doing this. And the reason I'm calling tonight is as a retired nurse and a longtime Red Cross volunteer, I am concerned with people getting the tests that need them. They've been distancing themselves, they've been hand washing, but they develop acute fever, chills, coughing, and want to get tested. They don't want to overcrowd the ER, overcrowd the doctor's office. How can we expedite people that want to also not really go into the hospital and be exposed to other germs? Is there a light bulb coming on of maybe proceeding with that testing at a drive-in like we give the UK T-shirts away? That maybe the Red Cross could be involved. I know the health department in all 120 counties could be involved, but I've always been one that we live in Lexington, we live in Kentucky, and I like us to be successful at doing out-of-the-box things. And I really appreciate Dr. Kennedy being there tonight, because I do know we need more education, and thank you. And I'll wait for your response.
Thank you. I appreciate Dr. Kennedy being here as well. Obviously, the health departments, if you don't have a primary care physician, and if you don't want to go to the ER, and by the way, it's not recommended to go to the ER unless you have emergent conditions. Dr. Ryan Stanton, who is a well-regarded emergency room doctor, has been public in stating that if you don't have any symptoms and you don't have any emergent conditions, we don't want to overrun these emergency rooms just to seek a test. A test should be sought only if you have a referral from a physician who can identify symptoms that would justify a test. But obviously, you can contact the local public health department. Also, we have a number of community health centers that would be available for a call as well. Dr. Kennedy, do you have any other suggestions for the caller?
I think I appreciate Winona's question basically, and the crux of the question becomes in a patient basically who has a cough and a low-grade fever. How do you differentiate clinically from 100 other viruses that are not COVID-19 from COVID-19 itself? And I think that the symptoms that she described, first of all, we're in the peak influenza season. We're in the peak time of year when other respiratory viruses, non-influenza viruses, typically cause self-limited upper respiratory infections. And so I think if your symptoms basically are minimal, you really have to step back a couple of degrees and again look at well-defined CDC risk criteria. Travel in an endemic area, close contact with somebody who has traveled in an endemic area, fever in excess of 100.4, in addition to the pulmonary complaints. But the nature of Winona's question basically is compelling, and the reason is that even as clinicians, short of testing, which is clearly in short supply and difficult to come by, we don't have a reliable clinical sign or symptom or test basically that says you have a rhinovirus infection from the common cold, which is very endemic basically in this part of the year, as opposed to you actually have undiagnosed COVID-19. And so again, basically in the setting of mild symptomatology, I would avoid healthcare systems altogether. And if your symptoms worsen basically and you do have risk factors, then I think it is appropriate to seek testing.
Winona, thank you for the call and thank you for the question. And Dr. Kennedy, thanks for your answer. This call has gone by very quickly, and we've got a lot of people, as you can imagine, in the queue to ask a question. Our time has expired for this evening, but we're going to take one more call and then a final comment. So, Claire, can you tee up the final call?
Yes, John in Lexington, you're live with the Congressman.
Hello, John. Thanks for the call.
Thank you, Congressman Barr. I have two quick questions here. I'll read them because I wrote them out. I thank you for doing this. And my first question is about this call. Will there be more of these calls, and how can we learn about them and sign up to make sure that we and others that would be interested can listen to them? And my second question is about the announcement today about the University of Kentucky and some of the other Kentucky colleges and universities. It would seem that canceling classes is not enough to protect students and staff because students are still on campus in residence halls, eating campus cafeterias, and aren't prevented from interacting with the public. If students were to contract this illness and if that were to spread, it would seem that we would then be faced with a more dangerous proposition to release them home once they've been exposed around the state and country, or to keep them on campus and then face similar crisis to what we've seen on these cruises where it just continues to spread within these small confines. So my question is, are you and your office having conversations with the universities about their responses? And isn't now the time to send students home and send staff home before the decision has to be made under far more difficult circumstances?
Thanks for the question, John. Let me answer the second question first. Yes, we are in contact with Berea College that, as you know, canceled the remainder of the semester and sent their students home. We're in contact with all of our colleges and universities in the area. You mentioned the University of Kentucky. We're in constant communication with them about that. I will tell you that the federal government is not making recommendations to schools, colleges, and universities. It is an institution-by-institution decision. At this point, we are not being asked to communicate to our constituent schools about this, at least not yet. And so, again, it is an institution-by-institution decision. As to your first question, yes, we will keep you apprised of future calls as this pandemic develops and as conditions require. We want to keep all of our constituents informed. We will certainly announce if and when we have another one of these calls. We want your feedback on the call and whether or not it was helpful to you. The goal here was to provide the public with as much accurate and timely information as possible. We know that people have a lot of questions, and we want to answer those both from the federal government's response and the medical questions, and that's why we invited Dr. Kennedy to be with you. If you want to stay apprised of our future communications, you can sign up to our e-newsletter. Go to our website, bar.house.gov, and you can receive emails that will give you updates through our e-newsletter platform. Also, follow our website for announcements of future calls and our Facebook page. We will be notifying the public of future calls like this. We've been doing these teletown halls, but obviously there's been a surge in interest because of the need for the public to get timely information on this. So with that, let me just invite Dr. Kennedy to say whatever final word he would like. And let me just once again, I know you're very, very busy, and we really appreciate your expertise. I know on behalf of my constituents, we're very grateful for your time and help this evening. Dr. Kennedy, thank you.
I appreciate the opportunity to participate, Congressman Barr. I don't have anything in specific to add at this point in time, but would make available the board-certified infectious disease clinicians in our practice in the event that you move forward with similar informational episodes like this in the future.
We really appreciate it. We appreciate your time and obviously the service that you and your partners are providing to the citizens of Central Kentucky at this time. And so to all of you who joined the call tonight, thank you very much for joining us. I do encourage all of my constituents to continue good health practices for themselves and their families, just basic hand washing. Basic hygiene precautions are being advised, similar to those used to prevent the spread of the flu and other seasonal illnesses. If you want more information, we do advise you to go to the CDC website for those basic hygiene precautions. Also, I'm sorry we did not get a chance to chat with everybody on the line tonight. We had a long list of questions. We just don't have the time to get to all the calls, but there will be an opportunity for you to leave a voicemail if you stay on the line. I hope you will leave a message and also let me know what you thought about tonight's call, and if you have any suggestions on how we can continue to provide important information and timely information about this to you and your family. Thanks again for joining us and for the privilege of representing you and fighting for your interests and values in Washington, and have a great night. Do stay in touch with us on our website and our Facebook page for future announcements of future calls like this. Have a good evening.